Okay, good morning, everybody. Thank you for joining us today for this webinar. So today we are here to discuss treatments for acute promyelocytic leukemia, or APL. And we have a great panel with us to discuss this. Just to do some a bit of housekeeping if you didn't see the information we displayed beforehand. So we won't be allowing anyone to speak or to share their camera or unmute their microphone. But if you wish to ask a question, please use the chat function. And I know a few people have already joined us on Facebook, in which case you can still ask us a question, just pop it in the comments below the video, and we have several members of staff looking out for those and sending them to me so we can still address those. Welcome everybody, and thank you to our panelists for joining us bright and early this morning. Hopefully it'll be a really good discussion. So just to kick off with some introductions then, excuse me. My name is Charlotte. I'm the Patient Advocacy Manager here at Leukaemia Care. And just to introduce our panel, so maybe we could start with Julie, if you want to just say who you are and what your experience is relevant to today's webinar.
Hello everybody, my name is Julie. I was diagnosed with APL in February 2017 and I've been in remission since January 18.
Perfect, thank you. And also Jamie.
Hi, I'm Jamie. I was diagnosed with APL in August 2019 and I finished treatment last year in July 2020 and I've been in remission for most of last year.
Great, thank you. And Angie?
Hi, I'm Angela Watts. I'm a haematology nurse in the NHS and I also work with Leukaemia Care as a nurse advisor on the Helpline.
Thank you. And last but not least, Amit.
Thank you. Good morning. I'm Amit Patel. I'm a consultant in cellular therapies and transplantation based at the Christie in Manchester.
Thank you for joining us, everybody. So, as you'll know, we're discussing APL treatments today. So any questions you have relevant to the treatment of side effects, long-term effects, or supportive care that's available during APL treatment, our panelists are here to answer the questions, so please do let us know if you have any of those. But I think what we're going to do to kick off is just ask Amit to say a little bit about what the current treatments are for APL and how those have changed over the last few years. So Amit, would you mind giving us a little bit of a brief overview to kick us off?
Thank you. So when I think of APL, of course, this is a subtype of acute myeloid leukemia. Probably about 20% or less of patients with AML, depending on the patient's age, will have APL. Probably about 100 to 130 odd patients per year will be diagnosed with APL in the UK. This disease, I think, has got a special place in every haematologist's and every haematology department, because this is a true medical emergency when a patient presents with this condition. And the sort of interesting thing about this condition is that although historically, so many decades ago, this condition would be universally fatal from early death due to bleeding, these days, actually, the mortality in the first month is generally less than 5%, and that's really, again, mainly from bleeding and respiratory complications. In the longer term, so if we look 5 years and beyond, we're now talking about survivals of north of 90–95%. So this disease actually has the best outcome out of any form of acute leukemia and any form of acute myeloid leukemia. So, you know, it's really been transformed with the current treatments available. In terms of what is available, we do split this disease up into low and intermediate category based on the white blood count at presentation being less than 10, or a high-risk category based on the white blood count being more than 10. For patients who are in the low to intermediate group category, those patients would be treated initially with Atra all trans-retinoic acid or high-dose vitamin A and arsenic. And that would be the standard of care, and has been for a couple of years since arsenic was approved by NICE. For patients who have high-risk disease, patients who have a white count of more than 10 at presentation, unfortunately, we don't have access to arsenic to use frontline. So those patients get Atra and chemotherapy. And I think the reason for that is we don't really have trial data to support a different approach in the UK. We don't have access to giving, for example, Atra with arsenic, with or without chemotherapy in that group. Although, actually, interestingly, there was a study a few years ago conducted in Australia called the APML4 study, where patients were given all three agents. But in the UK, the standard of care would be Atra plus chemotherapy. The chemotherapy that's most commonly used is a drug called idarubicin. It's a chemotherapy that's classed as an anthracycline. But in fact, patients who have different forms of acute myeloid leukemia can often be treated with two drugs, daunorubicin, which is a similar class of drug, anthracycline and cytarabine. And that can also be combined with Atra, but the standard of care would generally be idarubicin with Atra in the UK. Regardless of whichever group a patient would be in, the important thing would be to control the coagulation disturbance and the hemorrhage. And even if patients don't have any features of hemorrhage at the very beginning, the aggressive reversal of any coagulation disturbance is important. So everybody now is sort of very wise to making sure that the platelet counts are elevated, typically above 50. The clotting disturbance, usually measured by fibrinogen decline or prolongation of other markers of coagulation, those are generally very aggressively corrected. And in fact, particularly patients who have a low white count at presentation, so less than 10, where there may be limited numbers of typical promyelocytic cells in the circulation at that time, where there may be a suspicion that this patient could have acute promyelocytic leukemia, but the diagnosis hasn't been confirmed. Actually, most people assume the patient has this disease and treat with Atra until a bone marrow has been conducted and until the cytogenetic confirmation of APL has been made. And so, the risk now of somebody having significant severe hemorrhage because of either a delayed onset of treatment or because of not recognizing this patient's got APL in most hematology units is relatively low compared to what it was, some years ago. So I think that there's been, very good progress from that perspective. And in terms of treatment, even if somebody has got low to intermediate risk disease, and that patient starts on Atra and arsenic, because Atra in particular causes the white count to rise some 1 or 2 weeks later after initiating treatment, sometimes those patients need chemotherapy as well. So sometimes centers will give hydroxycarbamide, a tablet orally to control the white count. They may combine that with steroids, dexamethasone, particularly if the patient's developing respiratory symptoms or is showing signs of fluid overload affecting their breathing. And of course, if somebody's white count is very high and that's causing complications, they may actually also get, for example, a dose of idarubicin or a similar chemotherapy drug. In the past, if there was access, particularly in the clinical trial, some patients could be treated with a dose of Gemtizumab, which is an antibody which targets CD33, which is on the cell surface of these leukemia cells. But it's not that's not routinely available. So most people will get either oral chemotherapy or a dose of idarubicin. And then after the first month, and actually I have to say, most patients with APL take a little bit longer to confirm remission. So it may be 6 weeks, but after that sort of time period with the induction chemotherapy is completed, most people would expect to be in complete remission with either regimen. The vast majority of patients would be in remission. There may still be detectable evidence of disease using a molecular test, which is a PCR test specifically for the genetic lesion in acute promyelocytic leukemia. It's the PML-RARA or PML-RARA PCR test, which tests the translocation between the two different chromosomes, 15 and 17, in the majority of cases. That can still be positive, and then that is followed while the patient is in remission over a period of time, and that then you would expect to become negative for most patients. So then patients would continue with consolidation therapy and then maintenance therapy. And it's slightly different depending on whether somebody starts off with ATRA and arsenic, or whether somebody starts off with ATRA and chemotherapy. But the maintenance schedules do provide treatment to essentially reduce the risk of relapse, either in the blood or in the central nervous system. And most patients who have treatment induction with arsenic and ATRA, or have induction with ATRA and chemotherapy, but then get arsenic in consolidation or maintenance phases, would expect to have a very low rate of relapse subsequently. And even if somebody relapses, and let's say previously they had a arsenic and ATRA, they could have arsenic even as a single agent for reinduction, and that is successful in most patients. So it's the treatment landscape now for APL has become, I think, probably one of the major success stories for acute leukemia treatment. Very few patients now very few patients need to go to a stem cell transplant, either an autologous transplant where they provide donor cells themselves, or allogeneic transplant where someone else is the donor. Very, very, very few patients now need that treatment for relapsed disease that has achieved a second remission. So, I think upfront arsenic ATRA with or without chemotherapy has just transformed the outcome for patients. So, as a hematologist, and I'm sure, working in any sort of department, I'm sure Angela will have a similar view. The outcome for these patients has completely been transformed, and this disease is the poster child now for where we need to get to with other forms of leukemia and other blood cancers.
Great, that's really heartening to hear. I just wanted to pick up on a couple of things before we go on to our other panelists. It sounds as if, from what you were saying around the bleeding and the fact that treatment's so successful, that early diagnosis is one of the remaining challenges for this disease. Is that a fair assessment?
I think, Charlotte, that's spot on. I could not agree more. The early diagnosis still remains a challenge, and the reason for that is because this disease often presents with a low blood count rather than a very high white count, which typically is picked up by the staff in the hematology lab wherever the blood test has been undertaken, and also is being picked up by whoever's ordered the test. And often, patients will have a blood test in the community or in some other specialist clinic, where a slightly low blood test may not be that noticeable. It may not be that unusual in their practice, and therefore, it is something that still requires ongoing education. And actually, Leukemia Care has been very successfully running a spot leukemia campaign to try and increase awareness of this. During the current pandemic that we're in, and have been for the last year, there has been a drop-off in the number of blood tests done for other reasons. So not somebody who's got symptoms of bone marrow failure presenting to someone, and may have leukemia. Somebody who has very non-specific symptoms that we don't know the cause of those, but are having, as part of a workup, a full blood count. That practice is slightly less than it was a year ago before the pandemic, and therefore we are seeing patients perhaps presenting it slightly later than they may have done otherwise.
Yeah, I agree. It's a concern at the moment and something we're keen to change. And we've got this year's Spot Leukemia coming up, which will be even more important than ever soon. So yeah, definitely agree on that. I want to come to our patients next, to maybe contrast with what Amit said there. So Julie, on an individual level, how was treatment of APL for you?
I was diagnosed through a blood test. I had an annual blood screen and my white count was down, and I was advised to go back about 8 weeks later and check it. And then it was all systems go, red lights flashing. And before I knew it, I'd been diagnosed with APL, and I was sort of like in there within 24 hours of being treated really rapidly, which was a bit frightening, obviously, initially. And then you get to realize actually that's a good thing, because they're obviously trying to prevent something happening. So I had the ATRA and the arsenic regime, and fortunately responded very well to it. And everybody said, oh, I tolerated it well and all the rest of it. But the side effects of having that treatment was pretty challenging and pretty grueling, as I felt. And I think also I felt very alone at that time, because I didn't really understand what was happening to me, why it was happening. Had I done anything to cause it? Which all the doctors said, no, you hadn't. It's just one of those things that happens. But also there was nobody that I could sort of knock on the door and say, hey, how did you react to this? Or how did you react to that? So the treatment, as we all know, is pretty grueling. It's very intense. I had all the usual sort of side effects of sort of, dry skin. I had partial hair loss. I had terrible headaches, really bad, significant headaches, which took a while to get under control. And then this magic tablet I had, which was sumatriptan, which worked like a treat. And take one of those and that was it. And obviously fatigue as well, and breathlessness. I think I mentioned dry skin, and awful tastes in your mouth, which unfortunately have continued ever since treatment started. So some of the latent side effects, I think, are still very much a mystery. Would I be right to say that? I think what with joint pain, back pain, and other sort of symptoms. So but somehow you get through these journeys of your stays in hospital and your daily trips and weekly trips, and then you don't see anybody for a month and then you go back in again. So yeah, I managed it, I got through it, and now thankfully living in remission with checks every 6 months, which is reassuring, I have to say. Those checks every 6 months, it does make a difference.
Yeah, so it sounds as if that you reflect that success story and that the treatment's worked for you and you're well at the moment, but on an individual level it's still quite intense treatment, and the side effects are not something that you would want to experience. Is that a good summary?
Yeah, that's a good summary. And I think I think we've mentioned before in virtual support groups, it'd be really nice.
We're losing your
You're losing me.
Yeah, so you've gone really quiet for a moment. I'm not quite sure why.
Can you hear me now?
Just about. Not sure.
Oh dear. I don't know what's happened there then.
Shall I ask Jamie to speak? Have a go at unmuting and muting, and we'll come back to you and see if it fixes itself. Sorry, Jeannie. Jamie, did you want to explain your experience and how it was similar or different to what Julie's already told us?
Yeah, sure. I know exactly what Julie was about to say as well, because I go to the same virtual support groups as her. And you know, there are this whole bunch of side effects that we're all getting, and it's really reassuring when you're in those kind of groups, to see other people who have the same weird joint pain that you do, you know, years after. There was a long discussion about hip pain last time, I think, which is very interesting. But yeah, to get back to me, because obviously it's all about me. I was diagnosed with APL in August 2019. I went to my GP because I had like this really sort of delirious flu kind of thing. I was fevered, all my bones and joints were aching and spasming. I had a bunch of mysterious bruises, but I wasn't like, who would be worried about a couple of bruises, you know? Welcome to spot leukemia. So, you know, he decided that I was, in his words, a very unwell man. And he sent me to like the special admissions unit at the local hospital. They immediately whacked me on all sorts of antibiotics and stuff. They thought I probably had sepsis or something. Within a day, they knew it was leukemia. Within 2 days, I think they confirmed it was APL. I have no idea what happened at this point. As I say, it was an emergency presentation. I was delirious with fever. I was asleep a lot, and I couldn't see because I had what turned out to be a subretinal bleed behind my right eye. And apparently my left eye isn't very good, which is why I now wear glasses. But I didn't know that at the time. So I just thought, you know, I just had no vision at all. My right eye was doing all the heavy lifting, but you know, that kind of eased. So I went straight onto arsenic and atra, which was fantastic because within about a couple of days, I put on 2 stone. I had a white blood cell count of 190. I'd gone into differentiation syndrome. So they took me off those, sent me to another hospital in Cardiff for a potential blood filtering. Cardiff took it really easy on me though. They let me kind of get better from the initial impact of that arsenic and atra. Got my white blood count down until I was well enough to restart treatment. At which point I had differentiation syndrome again, but I was reassured you don't get that more than twice, so that was good. But they gave me dexamethasone to a steroid to beat that, to get my white blood count down, and hydroxycarbamide, which you know was just to give me some kind of treatment because you know I'd basically been without treatment for a month, just to give me some way of beating it. I finally came back to where I live in Swansea, to the hospital here where I'd started off my journey, back on the arsenic and atra. And aside from getting pneumonia, the liquid on the lungs, fluid on the lungs, and bronchiolitis, I managed to complete that first big induction 8-week cycle in a grand total of 3.5 months. In terms of the consolidation treatment, the normal routine is sort of 5 days of arsenic and then for a week, and then 3 weeks of 2 days. My biggest problem was actually coping with the 5 days in a row. I really struggled with that. I would fail my ECGs all the time, which you have to have before you have the treatment. And I was just getting really ill. At one point, they were worried that I'd had some kind of arsenic overdose because I kind of collapsed in the chair. But after a couple of meetings with my consultant and my team, I went to like having 3 days a week instead of 5. It just meant that I extended my treatment, and my employers were fantastic to just, you know, let me have unlimited time off to get better, which, you know, I know not everyone has that luxury, but I was in no rush to complete my treatment. I just wanted to do it properly and well. You know, I ended up in remission at the end of the first consolidation cycle, completed my treatment 6 months later. The side effects, like Julie says, you know, so hard. You know, I had a lot of cold sores, which I got acyclovir to take, dry skin, dry lips, weird like fingernails going on. I don't quite know what's going on there. I lost a lot of hair. It was about 2 weeks after I had the hydroxycarbamide, and I just, you know, my hair used to be down to here, so it was just, you know, all off because I couldn't really cope with losing it. and it's grown back really weird and thick, and I need a haircut, but that's lockdown for you. My mouth, oh my God, yeah. You know, my mouth hurt, my taste change, and my God, the fatigue, like Julie said, the fatigue is still something that's really there to this day. I think the main long-lasting side effect for me has actually been the whole aspect of having APL and having this emergency presentation. I think because you don't have time, it's not like when you have a test because you've got a mole, or you know, you've got, you know, breathing difficulties, and you have a test and it might be cancer, and you have like that, you know, couple of weeks or months even to wait to know, because it's just like you're in hospital and then, you know, your wife's telling you you've got cancer, but you're so poorly that you forget, and then she has to tell you again and again. You don't have time to come to terms with it. So the impact of that is really, really stressful. I've always struggled with my mental health, but I wasn't really looked after because they're trying to treat the cancer. I totally get that. But it was a case of have some lorazepam, have some diazepam when it gets really bad. And that was it really. And it was very difficult. It's only now that I'm really getting the help I need to get over it. I'm having like trauma therapy for PTSD, and it's really helping. It really is. I don't know whether you can do that kind of therapy earlier in the journey, or whether it's just something that has to come to a head at the end. But it was that's been the hardest impact for me from side effects wise, is the mental state that I've got myself into after it. But you know, I'm just happy to be alive. You know, I can complain about my knees all the time. You know, they're hurting, but you know, without arsenic and atra, you know, Amit said about how terrifying the survival rates used to be, and I'm just really, really thankful.
Yeah, I think also you're not alone in the mental health impact of these kinds of illnesses. And I wonder, Angie, if you could pick up on that a little bit for me. And when someone comes in to your inpatient ward, they've come through A&E maybe, or a particularly stressful experience, how do you and your team support them at that point?
So thank you, Charlotte, and thank you both for describing. I think as Charlotte said, when we get someone that sort of arrives at the haematology department, it can actually be that, you know, it is an emergency, that they may have come in. You know, we've had patients in the past where they've been on, young adults been on a football pitch, maybe not feeling quite 100%, but not knowing, as Amit said about, you know, sometimes we're not able to get blood tests done, and in a younger, maybe fit adult who's playing sport, there probably wouldn't have been a reason for them to go and get a blood test from a GP. They may have thought they were overdoing things, you know, at work or even, you know, socially at that time. So yes, it's all very sudden. We have to try and get that information and balance written and verbal information. So we are trying to focus on the whole person, as in, you know, physically and emotionally as well. So I would say that quite a long time ago, but about over the years, that things we do have attached to a lot of the haematology units are clinical psychologists. Some obviously areas are going to be maybe better well equipped in that sense. And again, although we do have facility, and we have what they call multidisciplinary team meetings, where we discuss a patient at sort of what's the plan for that patient's treatment, and we would involve that other healthcare professional in that meeting and sort of ward rounds almost. But as you, I think you said, Jamie, that you're not feeling very well, if we thought, there's a lot of people that are around you. So there's the haematology consultant, there are nurses on the unit, somebody might be coming in, you know, to sort out a line for you to have access for treatment. So in those very first 48 hours, I would say, there's such a lot of people around you. There's quite a lot of, I'd say not confusion, but there's a plan, but it's a lot to take in for you. And I do appreciate, we do try to get that balance, but sometimes when someone is quite sick and they're coming in and we have to try and get things going, we do try our best, and especially at the moment as well with no visitors. So anyone that's recently been diagnosed in that last year, unfortunately, as well, with haematology units, we haven't in a way that the patients had to come on their own. So I guess that's had quite a massive impact. But definitely we've got facilities to be able to offer some support. Maybe that's as an inpatient, and then obviously as an outpatient with leukemia care, we have access as well to that counselling, facilities as well now, don't we? So I'm not saying it's perfect, it's far from it, but we are trying to make some progress with that as well.
Yeah, thanks, Angie. It's reassuring to hear from a patient perspective, I guess, that you guys are thinking about it, even if there's only so much you can do at that point, which we totally understand. It's an emergency. Amit, I wondered if you could just explain something that Jamie mentioned. He mentioned differentiation syndrome a couple of times. Could you just explain what that actually is and why it occurs?
Sure. So one of the problems in acute leukemia is an excess production of immature cells, myeloid cells or precursor cells that will eventually become neutrophils and monocytes. You get that combined with a block in differentiation. So in other words, you're making too many of these precursor cells, and rather than them maturing properly and becoming neutrophils, they get stuck at the promyelocytic stage, and that's why you get an excess number of promyelocytes, and that's where the disease gets its name. With ATRA, it is unable to unblock that, and so though the high numbers of precursor cells that are being made, they can then differentiate into neutrophils, and that then causes the white cell to count to rise, and that's the sort of differentiation syndrome that Jimmy described. It's when the white count increases to cause leukocytosis or hyperleukocytosis, and as those cells differentiate from primitive cells to more mature cells, neutrophils, that process then can cause problems because, for example, those cells tend to be large and they tend to be quite sticky. And what they tend to do is then get stuck in the vasculature, particularly in the vasculature of the lung. And that's why perhaps even if not immediately at the time of presentation, but perhaps in the first couple of weeks, when the white count rises, those cells then get stuck in the pulmonary vasculature and they essentially shunt off bits of the lung. So in other words, they cause breathlessness because the ability of the lungs to exchange air is reduced, the capacity is reduced because of the blockage caused by those cells. And that's actually why patients get steroids, to make those cells less sticky and allow those cells to flow more freely in the vasculature. And that's why they get chemotherapy. So Jamie mentioned the hydroxycarbamide. That's the oral chemotherapy that's sometimes given if instead of an IV dose or two of something like idarubicin, or the leukapheresis that he mentioned. He went to have the white count was very high, and then the white count could fairly dramatically be removed physically by removing the excess white cells in the circulation. That's another thing that can happen. And again, they're all aimed at treating the same thing, the hyperleukostasis that results from the differentiation, and the differentiation itself causing the cells to get stuck when they shouldn't get stuck.
That's helpful to know. Thank you for that. And I guess just to go back to what we were discussing previously around the moment at which someone's diagnosed, and we're talking about fairly quick treatments, how is there enough time, if you like, to discuss these things with patients? How do we talk a lot about shared decision making and ensuring the patients are properly informed and things, but with something like this it must be quite challenging as a doctor to get information across around side effects and things like that, and how do you deal with that in that moment?
Yeah, I think as both Julie and Jamie have illustrated, I think that the emergency bit of it is the most challenging, because the treatment needs to get into the patient. the quicker that occurs, the less likely there are going to be complications. But that must be balanced with, making sure patients are informed about what's about to happen, what some of the limitations are, some of the side effects, immediate side effects, and some of the longer term side effects as well that we've heard about. Actually, it's very difficult to do that. Usually, once a diagnosis is disclosed, we think this is a form of acute leukemia. Not lots of other information is often taken on board at that time, because a lot of the time, as we've heard, actually, the diagnosis is not suspected. It's the symptoms are quite non-specific. There's been no time to get used to a possibility of a cancer or a blood cancer, and so it's a bit of a shock. Oh, I only had aches and pains or bone pains or fever or a low blood count, and suddenly they're in a hematology department and somebody's telling them they've got a form of acute leukemia. So once that has been discussed, actually that's not the time to have a long discussion about actually some of the limitations, because most of that information won't be remembered or taken on board. It's then repeating those and having those conversations again at later time points, perhaps when the patient's recovered, or perhaps prior to starting consolidation. That's the time that it's important to then continue to have those discussions. And actually, that's the time when most patients find support services such as psychological support services that they can access. We have that. We're lucky we have those, but not every unit will have readily available access to that. And I think that's the time when these other features are more important. And then I think in the longer term, so you've had the disease a year or 2 or 3 years, and actually you've still got bone pain or you've still got neuropathy, that then long-term survivorship support is really when it's most important, because the cancer's all but it's gone really. There's long-term remission there, but actually there are the side effects or the aftermath of that therapy that needs support, and that's, I think, that's where Leukemia Care and other services are absolutely critical.
Yeah. And Julie, did you want to say anything on that survivorship points? I think you were trying to say something earlier when we lost you.
Right, I don't know. Can you hear me now?
We can hear you now.
Better, yeah, I'm back in again. No, I think for me, I found the doctors all said to me, oh, it'll be at the end when it's all over that you'll have sort of a bit of rabbit in headlights, sort of, oh my gosh, what have I gone through? How have I managed to survive this? And I must admit, the counselling that I received from the hospital was really great, and enabled me to put everything into perspective. And I think that for me was key, because I didn't actually say this, but I'd also had breast cancer 10 years before in 2007. So it was a bit of a shock to think, oh, you've got through one and now you're being hit with something else, which was completely different. And I found those sort of sessions were really good just to manage my expectations of what I can now do, how it has impacted you, how it's affected your outlook on life, and I've often referred to life being this sort of, initially it was a shade of blue, and now it's a sort of a darker blue or a lighter blue, because life has moved on and it's, you're looking through a different kaleidoscope. But those tools were really helpful. But one tip I would definitely say is the Leukemia Care Buddy Scheme. I again contacted them in 2018-19 and was put in touch with the buddy, which was great because I was then able to talk to somebody else who'd had APL, even though her journey had been different. You could say, yes, I did experience that. Oh, yeah, you did too. And you think, oh, I'm not alone in this. It's not strange. And it is a common sort of theme, if you know what I mean. So I in a way would have been helpful if I'd have had that in 2017, but I was unaware of that tool. So all I would try and say is to anybody is just to try and promote that, because I think it really is helpful. And I, as a consequence of receiving that, I have become a mentor or a buddy myself. So yeah, and given that it's so rare, I think given that APL is so rare, it's so helpful just to bounce off somebody else what's going on. It may not be, well, we know we're all unique and it's not the same journey, but we all have similar questions that you might be frightened to ask a doctor, because the doctors are concerned about, my blood's okay, yes it is, off you go. You think, oh, I can't really ask this particular question, it sounds a bit daft. But to a buddy or somebody else that you know, you could say, hey, what do you think about this? And you get some sort of help with it.
Definitely.
Yeah, that's what I would help say.
And if anybody's wanting more information on the buddy scheme, it's coming up at the end again. I did show us them at the end, but thank you for your support with volunteering for that, Julie.
You're welcome.
Jamie, I wondered if there seems to be a theme emerging from our discussion today that the treatment, we're pretty confident it works, it's very good, but the individual patient still requires support. Does that reflect your experience as well? It's the emotional impact and the support that is really key for APL patients these days.
I think anyone who presents in that kind of emergency whirlwind, then yeah, because it's a shock, you know, whether it manifests itself as it has for me with this kind of you know, repressed trauma, or whether, you know, it's just getting used to it. It's really hard, and you know, I've got no problem with the way that I was looked after at the start. You know, what can they do? They can try and save my life. You know, mental health can wait until I'm a little bit better, but it was just as you're kind of going on the journey, you're not sure whether you're going to go into remission. Maybe you're going to be one of the 10% that doesn't get through it, and these are all the kind of things that a lot of other people with illnesses don't have to go through, you know, right at the start. They've already had these conversations, they've already had these thoughts, they've already been on Google, which is not a good idea. But you know, it is kind of difficult because, you know, the stresses of being in hospital quite often, because of our like low neutrophils and our susceptibility to illness, you put into individual rooms. I was in isolation for, you know, long before this lockdown. You know, I was like in a room by myself, wasn't allowed out. My wife had to come in wearing like a, you know, the whole PPE thing. You know, before COVID existed, we'd done that. You know, she'd have to wear an apron. All the staff would come in with shields and stuff. So it's really difficult to have that kind of understanding, because you're left to your own devices, and unfortunately at the same time you're very ill, you're very worried, and you're just bouncing off the walls. And I think that was difficult, and asking for help is the biggest part of it, because, you know, if I hadn't continued to ask for help, I wouldn't have got, you know, the tranquilizers that I needed when I was having massive panic attacks. I wouldn't have had the nice Macmillan nurse that came in and did Tai Chi with me, which is something I would never do before in my previous life. But, you know, it really helped. And, you know, I had counselling through a local cancer charity. And, you know, fortunately, I've got private healthcare through work. So I've been able to sort of jump the NHS waiting list, because obviously I'm not an inpatient now. I did see some psychiatric teams, they came in and visited me in hospital, but you know, it's a lot, you know, waiting lists are not fun for anyone. So I've got private healthcare, and you know, I'm seeing a therapist at the moment, and it's fantastic. And you know, the Anne Ashley Counselling Fund that Leukaemia Care runs, you know, if I wasn't in such a fortunate position right now, I'd have tapped you up a long time ago, because it's so important to ask for help, because there's so much that goes into that first couple of weeks of, oh my God, you've got cancer, you're really ill. That's enough to take in at the time. And just to get through that is the most important thing. You know, it's not a fun environment. It's not an environment where you can particularly like you know, Angie and Amit said, it's not a time when you can really worry about, you know, my toenails are weird, because you're far more concerned with, am I going to survive this week? Am I going to survive this fortnight? And like Julie said, you know, having that sort of buddy scheme is wonderful. I was lucky enough that by the time I was an outpatient, there was someone else who was a cycle ahead of me with APL in my hospital. So, you know, we didn't become like, you know, Facebook friends or anything, but, you know, we would sit there in the morning, compare our side effects, talk about our treatment, talk about our doctor, you know, it was just lovely to have someone else, especially as like she was this extra set on for me. So, you know, I could see how my journey would progress from there, and just to share stuff. So if anyone's like on this webinar who doesn't know, we've got an APL support group on Facebook, Leukemia Care APL support group, and we have like a meeting every 2 months, every 8 weeks, every 6 weeks, and it's fantastic just to be able to share our experiences with each other, because it is a rare illness and it's really tough. Yeah.
Thank you for sharing all that, and definitely if anybody needs any more information about the support group, please do get in touch. We've got a couple of more medical questions in the chat that I'm keen to make sure we address. Amit, could I ask you to comment on the question we have around not having as many side effects, and I guess I'm going to sort of twist that question slightly and ask you, is there a way you can predict side effects, or is it all very individual? What, you know, what causes side effects, and is there any way of predicting how well people will respond to treatment in terms of the side effects?
Yeah, the side effects are a problem, particularly with cumulative doses and long-term treatment. It's not easy to predict who's going to develop which side effects, unfortunately. And even in patients who have no pre-existing conditions, so for example, you know, if somebody who's got neuropathy, mild neuropathy from diabetes, who is likely then to get worsening neuropathy with arsenic, they could have the same or lesser degree of a problem than somebody who's got no prior problem in that regard. So it is problematic. I suppose the important thing is to just think about recognizing and reporting these things, because, you know, as Julie mentioned, for that particular side effect, there are drugs that can help improve symptoms. The neuropathy is, it should improve over time, but actually it can take a long time, and during that period, unless it's treated symptomatically, that, you know, it's going to cause undue suffering. And the sort of the cardiac thing Jamie mentioned is a real problem as well, in the sense that it definitely causes prolongation of this thing called the QT interval, which you measure, you know, it's a measurement on the ECG, and that the reason it's measured is, of course, if that prolongs too much, the patient can develop an arrhythmia, which can cause chest pain or palpitations, or, you know, and sometimes, rarely, a cardiac arrest, and that's why it's monitored. And again, the problem with that is it's so random in terms of who's going to have a prolongation and who isn't, and then treating it usually with electrolytes, you know, with potassium or magnesium or calcium, depending on what might need correcting. And these are not things that are easy to predict at all. There are no models to say who's going to get what. And also, in terms of reversibility, there aren't good models to say, you know, what's likely to persist in some form in the longer term and what's likely to completely resolve.
I think some of the effects that Julie and Jamie have talked about are more long-term ones, but are they things that where the cause aren't as well known as things like perhaps nausea and things like that. So fatigue is one of the ones where we're still not really 100% sure what the cause of cancer-related fatigue is. Are they more difficult for you to treat as a clinician?
So fatigue often is something in the first part of the patient journey, in terms of it's a cancer-related symptom when there's lots of cancer cells that are around. After achieving a remission, morphologic remission, and then subsequently a molecular remission, the fatigue that persists is treatment-related. It's not really directly cancer-related. And that, again, after stopping treatment, should improve over time. You shouldn't, that shouldn't be a hangover that stays indefinitely. Hangover things are like things like neuropathy or joint pains that then either don't fully resolve or can take a long time to resolve. And it's just very individualized. Some patients fly through without much of any symptoms, and some patients unfortunately get all of them. So it's just something to be aware of, and I think it's incumbent on all of us to be having those discussions, of course, up front when one is taking a consent for treatment, but that's not the best time to have that discussion. Actually, I think having that discussion again in the medium and longer term is probably more important in terms of, are you having these side effects, and sort of looking a bit more proactively at whether they're there and then what we can do about them.
Angie, did you want to say anything from your perspective around how you advise patients who are experiencing some of these longer term effects?
Yeah, so as Amit has said about the medium and longer term, there's been sort of fairly recently, but over time, there's been an initiative about survivorship. Amit did mention this earlier. And so what that means is that there are teams around the hospital settings. Yes, of course, there are. We do have regular follow-up. So initially, patients would be seen frequently, when they finish treatment, and then that would be gradually, sort of spread out, so maybe monthly, then 3 monthly, and over time they would relax those periods of time. But so initially, what Amit has said, that we're looking at sort of shorter term effects of treatment effects, and then the idea and the follow-up is to see, are there any longer term effects and side effects of the treatments. So there are teams now that are survivorship teams, and they're used to seeing patients, and you can almost say if someone's got fatigue, you may be able to point them and get them referred to sort of an exercise rehabilitation program, because we know that exercise does have benefit of improving, and we can sort of then sit down with someone, take that time. So as specialist nurses and survivorship teams, then we can sort of pull out and tease out what are the, is it something that's a physical side effect? Do we need to sort of, get someone to have some extra support, some counselling support? So it's almost having that clinic, having that support, but as Amit said, is focusing and providing that referral almost for those longer term, physical or emotional issues that someone might have. And again, there's sometimes it's about getting back into society. So of course we've turned someone's life upside down. They've been admitted to hospital. You've had this massive amount of treatment. We've taken people out of their normal environment. As Jamie said, they've been isolated in a room for weeks or sometimes a couple of months on end. So it's about sort of getting back into society. It may be that they can't go back to their current working role. So it could be then that we have to work with the patient. The doctor would perhaps do a letter for their employer. So again, it's sort of having time, like Amit said, to focus on what do we need to do next? How do we integrate someone back into society so that there's that less feeling of isolation and trying to deal with, say, the fatigue, but maybe getting back to work part-time. And so it's I think it's about a period of adjustment and sort of how can we help, get a patient and their family as well back into sort of you know, our normal daily life, really. So I would say there's much more emphasis about trying to focus on some of the side effects that are maybe going to be a little bit slower or there for the longer period, and trying to get someone to have that support for those longer term effects, I guess. From our point of view, it's trying to get them into the, do we know who will help support them? Because sometimes that might not be able to be done in a haematology clinic, but then as specialist nurses, as a team, we can sort of guide them in the right direction and work with the GPs in the community.
It's good to hear that that's definitely becoming more of a focus. And
obviously with the charities, you know, they're heavily involved. We know that, and you know, there's literature, there's the booklets, but there's also about having prior to the COVID, of course, the patient info days as well, and so the patients and their families, because I would say as well that of course it is about the patient, but then sometimes their family members want to help and they're not sure how they can help. So having those info days, the family members can come and they can, you know, if there's, say, fatigue, as you know, we have sort of seminars about fatigue, about sort of, you know, quality of life and how to put in some different practices so that patients can maybe rearrange their day so that they, you know, they maybe do things differently. And again, that could be really helpful for having their patient family member come with them so they know how to help them as well.
Yeah, definitely. That's a group often forgotten about, is the extended family and things like that. Definitely. Because
a lot of the time as well, Charlotte, employees won't understand our patients' needs. So if they do want to try and get back to work, because of that feeling of isolated and almost being sidelined from our normal daily life, if you've had quite a few months of treatment and then you've got to step back into a working environment, it must be really scary, actually. Where do I fit in with my colleagues, and how do my colleagues, you know, how can they support you, really? So I think it's very much, we need to perhaps do a little bit more work and around perhaps getting patients back into work.
Yeah, definitely agree with that. We'll wind up towards the end now, but I've noticed there's one question around oral and oral tablets, Amit, and I wondered whether you could just briefly explain whether people can expect to receive different kinds of treatments over time, and treatments that are delivered in different ways, and how this varies across sort of the treatment journey.
Yeah, so the arsenic currently that we have is IV, but there is an oral version that has been tested and looks like it's equivalent to the IV version. There are a couple of different manufacturers that make it, and it's not currently available routinely in the UK. But the direction of travel is to go oral completely, because of course Atra's oral as well. So that I think is something that we're really quite keen on moving towards, because that would make things very, very convenient for everybody, you know, in terms of lines, in terms of frequency of visits, and so on. So I absolutely agree. I think that in the later parts of the treatment journey, going oral, total oral would be very beneficial.
And I wonder whether Jamie and Julie want to comment on that. I guess thinking more widely about unmet needs, Amit's talked about how successful the current treatments are. And maybe Jamie first, what do you think is the remaining unmet need for treatment in APL? What if you were going to be treated again? Hopefully not, but theoretically, what would you have preferred to see in the future?
Yeah, absolutely. Not the great arsenic weight. It's even more annoying than any other drug, because it's kind of expensive. So, and obviously you're the only APL patient there is. So they don't have like a vast resource of it. in the chemist. They have to make it up, and they're not going to make it up if they think you're going to fail your ECG in the morning. So typically we would leave the house at about 7:30 in the morning, drive to hospital, have an ECG. Obviously, if the other APL patients got there in there first, I have to wait another 20 minutes to get my ECG. Then go upstairs and give them the results, and then you just wait for 2 hours, 4 hours, 6 hours until they actually come up with the bag of arsenic. So to have that in a tablet form would mean I wouldn't have to spend 3 really grueling days a week in the outpatients, and because it's really hard work. At one point when I was an inpatient, I was on more IVs. I needed more IVs than there were hours in the day, and I didn't like cannulas. I didn't like having this stuff pumped in me all day long. If you could just take a tablet, obviously all anyone wants is a magic tablet. I've already got that with the Atra, so if they're making an arsenic tablet, that would just be wonderful. That would, oh my gosh, that would just make life so much easier.
I think these are some of the things that aren't really appreciated in some of these illnesses that are life-threatening, is these things still make a difference. If we can, obviously a treatment that works is the most important thing, and then getting better versions of those treatments that work better for patients in terms of oral and things like that is the next step. Would you agree with that, Julie?
Yes, I would. And I think also it would also help reduce any side effects that you may have to having the ports, the lines that go in. I ended up getting blisters and I was allergic to chlorhexidine. So they had to find another way of dealing with that, which was another compounding impact that I had to psychologically deal with. So I think any magic pill would be absolutely fantastic. I certainly endorse what Jamie says. Thank you.
Great. I think the one last question I wanted to ask before we say goodbye, again, another one for you, Jamie, but it was around the pandemic. So I believe you're having treatment sort of at the beginning of the pandemic, and I wondered whether you had any thoughts on how that impacted on your journey, if it did at all.
Yeah, it did. It was very weird. Obviously you go into the hospital in January and February and there'd all be these signs like, have you been to Italy? Have you been to China? And you're like, okay, no, I've been here. I'm not allowed to leave the house anyway. I'm poorly. But it did kind of I've really felt for the staff, because obviously they're still coming to work. They're having to get used to having their glasses steam up from the masks, and they're having to try and do cannulas wearing gloves, which they couldn't do before, and all this kind of thing. It made it difficult for them. It's made it difficult for me. Having to go in and not have my wife with me was difficult. Because she was like my patient advocate throughout the entire thing. I was a mess, and she was the one that did all my talking on my behalf, which was great. And that kind of stopped, and so those last couple of cycles were very lonely in that perspective. And now it's even like, you go back for a biopsy and you don't go into a waiting room, so you don't see all your friends. You don't see all those familiar faces anymore. You don't have chats. It's a little bit isolatory. And then you've got the fun scheduling of checking in with your consultant. So instead of waiting in outpatients for an hour after your appointment time, like you often end up doing, because they're busy on wards and dealing with emergencies, instead you have to sort of have that random, I'll call you in the afternoon on Tuesday, and you don't know when it's going to be, so you spend the entire afternoon just waiting for the phone call. And oh my gosh, it is just like, did I pass? Was my biopsy okay? Were my blood tests okay?
Mm-hmm.
So you kind of lose that personal thing, which is already kind of lacking anyway, because I've been like this now in this sort of bubble since August 2019. I'm going to struggle to readjust to civilization when it reopens, because I've been from very neutropenic and really scared of getting ill, getting a cold off someone, I ended up in hospital for a day because I caught a cold, but they didn't know what it was, and they were really worried about my lungs and that kind of stuff. So the idea of getting COVID has just been terrifying on top of it all, because your immune system is so low. You worry about what's going to happen. My son actually got COVID a couple of months ago. We ended up just having, I was tempted to move out, but I just thought, if I did move out, found like an Airbnb or something, that what if I've got it and then I'm all alone and I've got no one to look after me. So that's been really difficult. So we kind of locked him in his room and cleaned everything and just sort of fed him food through the doorway, which is, it's awkward, but he's big enough and old enough to kind of cope with that. But you kind of, I don't know what it's going to be like. It affected my treatment, and I don't know what the outside world is going to be like. I work from home anyway, which is a massive blessing. So I've been able to, as Angie was saying, just go back gradually, manage my fatigue. That I couldn't work for a nicer company, to be honest. But when it comes to getting on a train and going up to London to an event, or going to an office somewhere, which used to be routine, that's where it's going to really kind of hit me. Whenever that happens again, I'll have been like 2 years without doing anything, and it is kind of frightening. So yeah, we'll see how I go. As you can tell, I don't stop talking at any point in time. So how I'm going to be when I actually come face to face with people, I'm really not sure.
I'm looking forward to that day myself. Hopefully it won't be too far away. Angie, I'm going to give you the last word on COVID, because I think it has dramatically changed, as Jamie said, the way we treat patients. So from your perspective, how has it been, particularly with acute patients?
Yeah, I mean, there's as Jamie said, I mean, actually, as sort of say specialist nurses that are not working on the ward, but more, seeing patients in clinic and being there at the beginning around consent, and hopefully everyone who's diagnosed would be able to have that nurse with them and the doctor when you get that first news. But sometimes we've not been allowed to go to the ward, so they're trying to limit the footfall again to protect patients who are in isolation. And also I'm hoping, like everyone else, that they are seeing patients, but I guess the sort of clearly some patients have, I know we're talking about APL, but in terms of diagnosis of leukemia, so obviously the acute patients are admitted, and they might, if it's sort of less urgent, shall we say, then obviously they may come to the clinic. So I think what we're hoping is less of that telephone follow-up calls, like you say, looking at the bloods and then phoning people later on in the afternoon. I think we're hoping for that face-to-face to commence again, whether that's going to be a gradual thing, and as at the moment sort of we're not so sure. So we've tried to adapt as best we can, like Jamie has said. And I think the struggle is about communication, trying to communicate with the patient with a mask on. In a way, some of the haematology areas have sort of been, hopefully that they've been COVID free, and I think it's sort of, I guess, the scary for everyone was having been admitted, and for patients with a haematology diagnosis of having COVID on top of everything that they're going through in the middle of chemotherapy, as being terrifying for patients. I think the good news as well, though, just to end on that, is that a lot more people have had the vaccine. So again, I think that we're, I say, excited about that, and I think that, like you say, that's the way more patients now are having the vaccine. So sort of rolling that out as quick as we can is hugely important. Definitely. So hopefully we want to be able to have that face-to-face and being able to support our patients again.
Great, that's a good place to end on.
Yeah, hopefully.
Oh, thank you for the slides. That was very prompt. Thank you to our panelists today. It's been really good discussion. I hope that people listening have found it useful. Just in case anybody missed some or most of the chat today, joined us late, we are putting this online so you can read it back. I think those are the wrong slides. Nick, if it's possible to change them. Sorry, that was distracting me. Yeah, this will be on YouTube afterwards, and we'll also be sending out a feedback form, which we really appreciate if you can fill that in to help us learn for the future. Here we go. These are the ones I was expecting. Thank you very much. So just to, I know we've mentioned a lot of our services throughout the webinar, but we want to make sure anybody who may have missed that is aware of them. So here's a variety of our information sources. We do audio, we do video, we do written, so something for everyone there if you're looking for information about APL. Just a word about the buddy scheme. We are looking for more APL buddies, both to support and to be supported. So if you want to help or if you're looking for support, please get in touch. Here's a list of our other support services. We've mentioned the counselling fund already, of which I've got more information on the next slide, please. There we go. So yeah, we fund up to 6 sessions of counselling. If you've not been able to access it through other services, I know quite a few people don't. There's plenty of information on how to apply on our website there. And final slide, please. Oh, there we go. And there's our details to get in touch, which I'll leave up as I say thank you. I know there were a couple of questions we weren't able to answer. Amit unfortunately had to leave us at 10:30, so I've made a note of those and I will get in touch with anybody who's got any outstanding questions. Please do get in touch with us if you've got any outstanding questions or anything you want to ask about today's webinar. Thank you again to our panelists. It's been a really great conversation. Thank you for your time and for sharing your experiences. And I hope everyone has a lovely rest of the afternoon. Thank you, everyone.
Thank you.
Bye.
Thank you. Bye.